Hey guys, I'm just gonna do another study video if you guys are interested. This one's gonna cover the different numbers for the cardiac rhythm intervals and the waves, and also look at some of the different dysrhythmias or normal cardiac wave patterns, just to help us study it a little bit more. I've been studying Quizlets and trying to listen to the UJAs. I really liked Annie's video on EKG strips. I really thought that helped me just have a better understanding of how to read them. After watching her video and just looking at more of the cardiac strips and using a little bit of Quizlet, I think there's a pattern that goes with these dysrhythmias that can kind of help us divide them and make studying a little bit easier. So some of the first things I want to go over are the just normal intervals that we should know. And in case you guys were like me last year, it took me a lot of time to figure out what box I should be looking for. And you see this chart here? This is our old PN book. Hope you can see it, but one of those really tiny boxes, and then it has this box, and then that's your, I believe, is your 0.4 second. This little tiny box here is your 0.4 second, and that's going to be important to know for the different measurements of intervals. It took me a long time last semester or PN year to actually understand that that's the box that we were looking for, so just wanted to clear that up if anyone had that problem that I had. And also this chart here, if you have your PN book, that would be good to look at as well. Alright, so now we'll get that out of the way. Let's see the PN book. So on page 763, the chart on the table on 35-2, EKG waveforms and intervals. So the P wave, the normal duration for that is 0.06 to 0.12. And then the PR interval, that is 0.12 to 0.20. And the PR interval, there's a lot of numbers here and it's easy to get confused, at least for me. So when I'm thinking about that, I'm thinking about puberty range, PR puberty range, and I'm thinking that it's 12 to 20. So that's how I'm thinking about that number. The T wave, I'm thinking about just 16, because it's like 16, emphasize on the teen, and then that's how I'm thinking about the T wave. If I can eliminate some of these numbers by having a kind of like a memory trick, then it'll already cut down on the amount that I have to know. The QRS complex, we want that less than 0.03. So for that, I'm thinking QRS, it's 3. So the QRS complex, it's a complex, and we want it less than 3 because there's only 3 letters, QRS. And then just remembering that for a lot of the rest of these numbers, you want it less than 12 or you want it 12, like the ST segment, you want that 12. The QRS interval, you want that at less than 12. The P wave, you want that 0.6 to 0.12. And the way I'm thinking about that one is it's P wave, and I'm just thinking of maybe pregnancy, like the first 6 to 12 weeks, it's kind of like a wave, because that's when you might find you're pregnant, that's when you might have a lot of your prenatal testing, procedures done, things like that, or just a lot of excitement there. So that's what I'm thinking, like the first 6 to 12 weeks, P wave, pregnancy wave kind of thing. And I think that's also right when you probably have morning sickness too. At least it goes up until 16 weeks. So just thinking P wave, 6 to 12 weeks, PR interval, puberty range, 0.12 to 0.20. QRS complex, it's a complex of 3, so we want it less than 0.3. QRS interval, we want that less than 12. ST segment, we want that at 12. T wave, we want it at 0.16. Something about 16 again, because teen thing. So So that's how I'm helping. That's what I'm using to help me remember those values. And then the SA node and the atria, that's your normal pacemaker, and that's gonna be at a beat of 60 to 100 beats per minute. The AV node and the bundle of his, that's gonna be what takes over if the SA node fails or can't get the signal conducted properly, and that's gonna be 40 to 60. And then finally the bundle branches and the Purkinje fibers, that's going to be your like last resort, and that's going to be a beat of 20 to 40. And the Purkinje fibers, that's coming from the ventricles, and you never want it to get that bad because at a rate of 20 to 40 it's just not sustainable and you're not going to get the cardiac output that you need. So a ventricular conduction or a conduction initiated from the ventriculars, like bundle branches, Purkinje fibers, you never want that to happen because that's dangerous. And let's see here. Just reload in here a little bit. Okay, I think we're gonna go off of the PN book, PowerPoints, this, the rhythm analysis points, and I also found this in my, I guess you could say, notes from A&P class actually, and it's a little chart here, and it has the different like rhythms and things you should know. So I found that, I believe, on, it was something our instructor posted as a resource, but you can probably find it on Pinterest and things. But some of the things I thought that were interesting for this was that fibrillation, and also on the other charts, if you look at it, let me just see, like flutter has more of like a wave to it, and then if you look at fibrillation, it's more of a kind of like a just, you know, it's not as smooth. So flutter, just see this, okay, so flutter is going to be more wave, like you're fluttering like in the ocean kind of deal. And then if it's fibbing, then it's just like, it's like you're fidgeting, you know, it's not good, it's all like messy, you know, it's fibbing. And then Annie went over this really well, so if you haven't watched her video, I highly recommend it because it really helped. And also, like from this chart that Annie gave us, probably have to pull that up, but hers, this is like a flutter, and you can also see that like at smooth like waves here, that's for the fluttering, and that's for the atrial flutter, and you can tell because that's, yeah. Yep. And then here you have your atrial fibrillation here, and that's when it's not smooth, it's all more like disjointed and stuff. Okay. And then for your V-fib here, it's kind of like the same thing. It's not like a nice smooth waves. These have peaks to them, and this is the ventricular fibrillation. So they have the peaks. It's not like a smooth wave. This is the ventricular fibrillation. This is when they have like the sharp peaks. Okay. And then the asystole, that's when it's just completely flat, because asystole means like A is like abnormal or absence in some cases, and then like if you have asystole, it's like no signal. Okay. I'm just gonna go through the PowerPoints here and just kind of like study as I go along. So, and then she has her like first PowerPoint here. She put it in here. It's probably important to know. So you like chocolate in the center, white on the right, snow over grass, and then you have smoke over fire. And then when you have like a person coming in with a cardiac problem, one of the things you're going to want to make sure that that's done as a nursing intervention is you're going to want to make sure that they're put on a 12-lead EKG. And you want them on a 12-lead EKG instead of like a 6-lead or any other lead, because the 12-lead EKGs, they show more of the dimensions of the heart and like where the signal's coming from. Like here they have all these different like planes that they're looking at for the EKG, like that's why it looks kind of confusing, and it was confusing for me until I learned about this, is that they have different printout things because they're looking at the different planes or the different dimensions of your heart. And then, as we studied before, the way that you tell a rhythm or the rate for a cardiac strip is you just count the tops or the highest peak of all these different waves, and then you multiply that by 10, and then you should get your rate. So like if I count all the tips, and I go like 1, 2, 3, 4, 5, 6, 7, 8, and then I times it by 10, then I have a rate of 80. And then that's kind of a way you can tell from heart strip if it's tachycardia or it's bradycardia or if it's normal sinus rhythm, because if you have a rate that's, let's just say, like if you have a rate of, just trying to think of this, like if you have a rate, like let's say you have 13 of those peaks in a 6-second strip. So you have 13 of those, and then you times it by 10, you're going to have a rate of 130, and that's tachycardia. So you know that whatever rhythm you're looking for, it's going to be tachycardic. And then if they're looking at a rhythm and it's only 4 of those peaks, then you multiply it by 10 and you get 40. So then you know that whatever wave you're looking at is going to be bradycardic. Let's see. Yep. As we mentioned before, you don't want your conduction signal coming from the ventricles, because that's only going to be 20 to 40 beats, and that's just not going to be enough cardiac output to sustain anybody. So you want to make sure that you do something if you see a rate that's too slow. Okay, so evaluation of dysrhythmias. So some of the things we meant you want to do is the continuous EKG monitoring. You can do a Holter monitor where they'll just be wearing it in their daily life or whatever, and then they'll usually they'll have a diary and they'll write things down, and then you can just see from that like when are these dysrhythmias occurring. Sometimes when you might go to these dysrhythmias, they're not very consistent, and there's really no way to they just happen occasionally. You can't really predict when they're going to happen, so you can't go to the doctor and then guarantee that they'll assess a dysrhythmia because you don't know when they happen. So like Holter monitor is good for that. Event recorder monitoring is another thing. Exercise treadmill testing. They'll wear a little monitor, and then they'll be exercising, and then you can just see how their heart responds to exercise, and if they have any exertion induced dysrhythmias. And then sometimes if they can't do like a physical thing, then they'll accelerate the heart or cause the heart to have some type of exertion using medication. I believe there was. I just want to see if I can find the medication here. I got pacemakers too. I don't have it here. Let's see if it's here. Well, it might even be in a different chapter, but just know, like, sometimes, like, when they want to do like exercise or treadmill testing or something, then they can do it either like putting you on the treadmill, or in some clients, and they'll do it with a medication. They also can do electrophysiologic study, cath lab, that's invasive, and for doing cath lab things, and like I think they call it catheterization or cardiac cath. They have a high risk for dysrhythmias, and even when we went and studied like our coronary artery disease chapter, if they have a cardiac catheterization, you're really going to want to watch for dysrhythmias, because that's one of the biggest things that they're at risk for. Okay, first wave, sinus bradycardia. So bradycardia means slow heart rate, and that is less than 60 times per minute. And this is what it looks like. If you have your PowerPoints, you can look at those. But we can just count these, and then multiply them by 10. And that if it's less than 60, then it's going to be the sinus bradycardia. And it says, okay, normal rhythm for aerobically for athletes and during sleep. So athletes, they exercise a lot, and their body adapts to the higher like stress, or it just gets used to all that exercising. So when it's not exercising, then their heart's at a better rest, because they've adapted just to a lot of that exertion. So that's normal for them. You're going to want to assess for signs and symptoms, like if they're like dizzy, if they have hypotension, if they have poor cardiac output. But if they're asymptomatic and they don't have any problems, then it's not an issue. It can also occur if they have a carotid sinus massage, and like that's like here, like if you like massage this a lot, then someone could pass out. I actually read some place that like if you want to do like a self-defense thing, you just like massage it enough and the person might pass out. I'm not sure if that works or not, but anyway. If they have increased vagal tone, side effects of medications, so like if you have a beta blocker and you take it and your heart is already low, then this could cause sinus bradycardia. It can also happen in hypothyroidism, and hypothyroidism is just the body doesn't have enough of the stimulating like the thyroid hormone, which just gets everything just makes everything energized. So if you don't have enough of that, then everything's going to be slower. If you have increased intracranial pressure, then it just pushes on these centers, and then it kind of like as a defense mechanism type of thing, it just causes your heart rate to decrease, and that can also make like decrease your blood pressure too. Inferior wall MI. So, and then one of the ways, yeah, okay. And then also, okay, so it says you can have hypotension, you can have weakness, you can have pale, cool skin, you can have angina, dizziness, or fainting. So one of the treatments is atropine, and that's just a medication that you just push it, and then it increases the heart rate. But you don't want to do that long term. If it's something that happens like chronically or long term, then you're going to want to do a pacemaker. And then sinus tachycardia, you do the same thing. You just measure those peaks, and then you multiply them by 10. And then if it's greater than 100 beats per minute, then you have sinus tachycardia. So some of the things that you can see with this would be like pain, exercise, or like hypovolemic shock. So we just think of it as like tachycardia. And because it's going so fast, you're not getting the good filling, and you can have decreased cardiac output just because it's not doing the proper like filling and then pumping, filling, then pumping. It's just going like, so it doesn't. You can have decreased cardiac output. And then because it's going so fast, it's going to need more nutrients, it's going to need more oxygen. So if it's going like this and it's not getting what it needs, this thing's heart's going to start getting tired, and then you can have angina. So with the tachycardia, you can have adrenergic blockers to reduce the heart rate. So, and I'm also thinking beta blockers. And then you can also have the adenosine, and that's if you're not responding to the beta blockers. And then you can also have the tachycardia if you have fever, because if you have fever, then then it's trying to circulate the blood so that just like how I'm thinking, like if you have a lot of heated blood, you want to like circulate it so you can kind of like help cool it off. And you'd want to use your antipyretics to treat the fever, and analgesics to treat pain. And then that should lower the heart rate if it's caused by fever or pain. So I'm just trying to think about, there's a lot of stuff to think about with this chapter, so I'm just trying to think about it as I go along. So you can have the premature atrial contraction, and you have and what's causing this is an abnormal pathway across the atrium, and this can cause a distorted P wave. So a lot of times when I'm thinking about the P waves, if there's any kind of problem with the P waves, I'm thinking that it has something to do with the atrium, because in the beginning it's the atrium's play, and then once you have the QRS, then it's more of a ventricular thing. So the premature atrial contraction, you have a distorted P wave, and this is what it can look like here. And then with premature atrial contractions, you can have these, and it could be like emotional stress, use of caffeine, tobacco, alcohol, hypoxia, electrolyte imbalances, and it basically just feels like your heart like skips a beat. Like if you drink a bunch of coffee and then your heart's just feeling like a little bit, just like you're all jittery, and then sometimes it feels like your heart's a little bit jittery, and then it goes like a little bit fast sometimes, or it just has an extra beat when it shouldn't be there. Then you could be feeling premature atrial contraction, because it's just a little bit more there's a little bit more excitement in the SA node than there's supposed to be, and then you can have you can just have it like going off instead of at the SA node there. If you are a healthy individual and you have this, then it's not an issue. But if you have heart disease, or you've had like other dysrhythmias, or if you've had heart failure or anything like that, if you have any kind of cardiac condition, then this could be an issue, because it could be like a sign of a bigger dysrhythmia problem. So treatment for that, you can have beta blockers, reduce or eliminate caffeine and smoking. A lot of times with clinicals, if a person smells of smoke, or if they come in with smoke, or if they've been suspected of like chewing or anything like that, and they have been chewing, I'll notice that their heart rate's really, really high compared to like a normal person. So you can also have this with smoking too. And then next is the proximal supraventricular tachycardia. So the proximal is like coming and going. Supraventricular, that's like in the upper ventricular, the upper ventricles. And tachycardia means it's fast. So this is just going to be like a series of premature ventricular contractions, and it can just come and go whenever. So here's an example of that. So like here it's like normal, and then here you have the proximal, and then you have a whole bunch of the ventricular contractions, which is the QRS complex here. So it's like normal, and then all of a sudden you have proximal, it's happening out of nowhere, and then you have the ventricular contractions. So, and then this can happen like if you have overexertion, emotional stress, stimulants. You can kind of like think of this like if you're just out jogging and maybe you're out of shape, maybe you've been in nursing school, it's the first time you've run in a couple weeks, then you can just feel like your heart like just like kind of like pounding, you know. Then, and it also feels like it has a bit of an abnormal beat. It's going like faster than like maybe it should. Like it's like normal is like lub dub, and here you have dum 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 dum. Then maybe that's what it could be caused. You can also have this with digoxin toxicity and cor pulmonale, which is right-sided heart failure related to pulmonary issues. Okay, clinical significance, you can have prolonged episode and heart rate that's greater than 180 beats per minute. And you might also have like other symptoms, like you could be anxious, you could be very like just sweaty about it. So the vagal maneuver, one of the things our instructor talked about a lot was blowing through a straw or just bearing down. Then you can also have IV adenosine, and that's a rapid push, and you want it in an IV set that's close to the hearts. You're gonna monitor them with an EKG. And once you administer the adenosine, then it can cause a asystole, and that's going to be less than about 15 seconds. And the reason that they go and administer this medication is they just want everything to reset. And then once you have like a break or like a fresh start, then they want the SA node to kick back in, and then you just have the one rhythm there. Synchronized cardioversion, choice of therapy for hemodynamically unstable ventricular or supraventricular tachyarrhythmias. So if they still have a pulse, then you can do the cardioversion, and what it's gonna do is it's just gonna like when you have the Q or S wave, then when they have the R, then they're gonna give a shock, and then they're gonna in hopes to just like instead of like stopping the rhythm, they want to just have it at the R and then just take over the rhythm and then just have it go back to normal. At least that's how I'm understanding it. I might not understand it correctly. I'm still trying to study this, and there's another day left, so what I'm saying is just kind of the way I understand about it, and I might like figure out something later as I go along. So the atrial flutter, that's when we're gonna see I don't know. That's when we're going to see a little bit more of those like smoother waves. You have atrial tachyarrhythmia, so it's going to be a little bit faster than it's supposed to be. You're going to have regular sawtooth-shaped flutter waves. Originates from a signal place. Usually occurs with coronary artery disease, hypertension, valve disease, COPD, and digoxin. So this is what it looks like here. I'm just going to compare it with this one. So here they have it like this, and it looks kind of like smooth, but it still looks. And here they have it more of a sawtooth shape. So, but it still looks better than the atrial fibrillation, because with AFib, the lines are so tight, it's hard to see like any pattern at all. With this, sometimes they look more smooth, and then other times it's going to be more of a sawtooth shape. So with atrial flutter, you have high ventricular rates, loss of the atrial kick that can decrease cardiac output and precipitate heart failure and angina. So you have a risk for a stroke due to thrombus, the risk of thrombus formation in the atria. And that's also the same with atrial fibrillation. Anytime like the atrial aren't getting all the blood out of there, then you could have the clots that just like form in the residual blood volume with the atria. Like, blood is supposed to flow. If it's not flowing, then it can stagnate. If it stagnates, you can have all the platelets, and then they start accumulating, and then they make a clot. So anytime you have atrial fibrillation or you have atrial flutter, you have to really worry about clots. And then if you're worried about clots, some of the things you're going to want to do would be like anticoagulants, so like warfarin or heparin. I believe there was something I was studying in the other chapter about heart failure or like MIs, and it was that if they had atrial fibrillation for a certain amount of time, then it was okay to do a cardioversion. But if it was over a certain period of time, then you would have to have them on anticoagulant therapy first for a couple days, and then they would try the cardioversion. And I believe that was also on a quiz. So one of the things I would recommend, let's see if I have it here. Anyway, but just know that, like, if they've had atrial fibrillation for a certain amount of time, then you're gonna want to have them on anticoagulants first, because there could be clots in there, and then if you do the cardioversion or something and you just like shock it, then you might get those clots out of there, and then they might go into a coronary artery, and then you could have like a heart attack thing there. They could go into your brain, cause a stroke. They could even, I guess, travel into your lung and cause a pulmonary embolism. So with atrial flutter, you need to slow the ventricular response by increasing the AV block. So you're going to need drugs to slow the heart rate. You could try beta blockers. You can try anti-dysrhythmia drugs to convert, so like amidrone. We'll just use medications here. You can see them. And then, as we mentioned before, they're going to be on an anticoagulant while in atrial flutter because of the stroke risk. Let's go to some other things we can study. So atrial fibrillation is the most common dysrhythmia. I had a family member who had atrial fibrillation. It's also something I've had clients at clinical. I've had quite a few of them that had AFib or history of AFib. What it is the disorganization of atrial electrical activity due to multiple ectopic foci. So basically what that means is there's a whole bunch of areas in the atrium that want to have their own signal. There should only be one signal, and that should be the SA node. But with atrial fibrillation, it's very excited, and then you have all these different spots, and they're like, me, I want to do it. So then you have atrial fibrillation because of, instead of just the one SA node, you have a whole bunch of all these other spots, and they want to be the SA node too. So, and because it's not happening as one signal, it's happening in all these like different multiple signals, you're not going to have as strong of a contraction, and that's just going to make it like ineffective and irregular. And it also increases with age. Family member that had this is probably, I don't know, like 70s around there. There aren't many kids that have this. And you can also have the the QRS complexes all over the place. So you have like here's a picture I really like because it has all the different spots of where they're trying to have the signals, and then you have the QRS. There are a lot more of them, and they're also not very regular here. So, and then here's where we have the atrial fib. So it usually occurs with coronary artery disease or heart failure, cardiomyopathy, pericarditis, age, acute causes. You could have it post-CABG. And then because it's happening so frequently and it's not effective, you can have decreased cardiac output. And then if you have AFib and it's just going off like this, then the SA node is the pacemaker of the heart. So if it's ineffective and it's going off like this, one of the things it also controls will be like the ventricles. So if it's going like this, then the ventricles are like, hey, that's our signal. So then they're gonna try to like go faster, but their form is gonna look good because it's not the problem with the ventricles, it's the problem with atria. So you're gonna have these guys and their P wave and stuff isn't looking good, but then you have the frequent QRS waves and they still look good. You're gonna want to have neurochecks if they're on a blood thinner too. So beta blockers, calcium channel blockers, digoxin, long-term anticoagulation therapy, warfarin. Here's some meds. And then treatment to convert the sinus rhythm, you can do a pharmacological conversion, and that's going to be with the amiodarone, or you can have electrocardioversion. But if it's been AFib for greater than 48 hours or 2 days, warfarin is recommended for 3 weeks before the electrical cardioversion and for 4 weeks after. So that's where I read it. Yeah, if it's greater than 2 days, clot might have formed in there, so you don't want to do the electrocardioversion. But I think you still might be able to do the pharmacologic cardioversion. That's something you might want to check in, just if they can do the pharmacological or the electro. And then if it's controlled AFib, that means that they can live with it and it's not like seriously affecting them. You're just going to be able to like see it on EKG, see it when they have like heart studies, but it's not something that's like a huge like serious priority or big problem for them. And then junctional dysrhythmias, that's in the AV node. And that would be if the SA node has failed or if it's blocked. You're not going to have a P wave. And if you do have a P wave, then it can be inverted. You can have atropine if it's symptomatic. If it's caused by digoxin toxicity, then you're going to hold the digoxin. You can also use beta blockers, calcium channel blockers, and amiodarone if it's tachycardia. So with this one, you're going to want to find out like what's the problem. Like, is it digoxin toxicity? Like one of the things that helps with my nursing exams is I try to use the nursing process as much as possible, and the first step with that is assessing. Before you choose any nursing interventions or anything that you're going to do, you want to get as much information as possible. So if there's a question that and assessing is an option, then I'll usually pick it first before choosing any other options, just because I might not have enough information currently to make a good decision. And then if I start making decisions, I might find out that I'm missing some information. So assessing like if there's a underlying problem, or assessing if there's something else I should know, that's always a pretty good bet for me. And then there is the AV heart block. chart here. And then there's also a chart in our book. Okay, that's on page 764, table 35-7. That's something I'm studying, and I'm going to be studying more tomorrow. Definitely. And I'm just gonna finish up with a little couple more of the ventricular dysrhythmias. So we have premature ventricular contractions. They're usually benign, but we want to monitor them anyway. In heart disease, they may decrease the cardiac output, and then they also might cause angina and heart failure. Or not cause, but just come before. Treatment, you're going to want to figure out what the cause of it is. Take the apical pulse to determine the rate. Okay, so here's the other ones I'm going to look into. So the ventricular tachycardia, that one's dangerous. You can also have them be pulseless in VTach. So you could just have it like, here's what it looks like. And on the chart here, it can also look like this. This one here. And then it can be regular, no P waves, wide QRS, and run of 3 or more premature ventricular contractions, can be continuous at a rate of 150 to 250. It's considered life-threatening because if it's going that fast, these are your ventricles, they're not your atria, where you can develop clots. These are your ventricles, so these are the big boys that actually pump your blood. So if they're going like really fast, you're not getting the cardiac output that you need because it's just not filling. It's like pumping and trying to fill at the same time. So it's really not helping. So they're life-threatening because you have decreased cardiac output and you also have the possibility of a ventricular fibrillation. And then ventricular fibrillation looks like this. It's just all over the place and it's no pattern. It's unstable. See? And you're not actually having the good contraction because you don't have that normal QRS complex there. Let's see. So for the ventricular tachycardia, it can be caused by an MI, coronary artery disease. You can have electrolyte imbalances, like you can think of like your potassium. Potassium can cause a lot of dysrhythmias. Cardiomyopathy, mitral valve prolapse, digoxin, toxicity, central nervous system disorders. If it's stable, then they're going to have a pulse, and they're not going to be like having like a whole bunch of like indication that there's something wrong. If it's unstable, then that's when you're going to have your symptoms, and it can also be pulseless, and then that's when you're going to have your cardiac arrest. So if it's sustained ventricular tachycardia, then that's when you're going to have a lot of your decrease in like cardiac output, and that can cause things like hypotension, pulmonary edema, decreased cerebral blood flow, cardiopulmonary arrest. And some of the treatments for this is administering medications. I'm not going to try to pronounce those. There should be a table in the book too. If you don't have a pulse, then you're going to call code, and then you're going to start CPR and defibrillation. So you're going to do epinephrine. You're going to do epinephrine to start the heart. So I'm not quite sure I did a little, there's something like, if you don't have a pulse, then you're not going to want to defib them, because there's nothing to, like a defib, it kind of like resets everything. It like gives it a shock, and then you wanted the heart to go back to normal rhythm. But if you don't have a underlying rhythm or anything, or if you don't have any electrical conductivity there, then shocking them is not going to do any good. You don't want to shock somebody when they're asystole. You don't want to shock somebody if they don't have a pulse. So yeah, if they're flatline, asystole, you don't defibrillate them. You do the chest compressions. So AFib, you defib. That is ventricular fibrillation. This is when it's all very irregular. Severe derangement of the heart rhythm, characterized on an EKG by chaotic waveforms, no effective contraction, or cardiac output occurs. So this is what we were talking. It's just, you don't have your normal QRS segments. It's all over the place. It's not working. It's not acting like a pump. It's just messed up. So with this one, it still has a pattern. It still has a conduction, and then defibbing them will work because there's something that you can work with. If it's asystole, there's nothing you can work with. You just have to manually do it. But if it's AFib, and you can still have those irregular waves, then you can just shock them back into place. If you don't have those waves, then there's nothing you can shock back into place. Yep. So yeah. So the treatment for asystole, that's when you don't have any wave. It's just a flat line. You're going to do IV therapy with epinephrine and atropine. And then you can have pulses of electrical activity. So that's when you can have electrical activity on the EKG, but there's no pulse. You're going to want to know what's going on there. The only way to treat is to start CPR and correct underlying cause. So defibrillation, that's when you would do the ventricular fibrillation and the pulseless ventricular tachycardia. So, okay, so if you do not have a pulse with ventricular tachycardia, you can still defib them. It's just with asystole, then you wouldn't do it. So the shock depolarizes the cells to have an asystole to allow the SA node to resume the pacemaker role. So this puts them in asystole, but it's gonna work. They're hoping it works in this way because you still have the SA node that's still generating some kind of a signal. It's irregular and it's all messed up, but it's still something that the shock will hopefully put back into place. If it's asystole, then there's nothing they can shock back into place, and that's why if it's asystole, then you just have to do the chest compressions. And then also with the pulseless electrical activity, you're going to want to do the CPR. You're going to do that too. So you can have a monoplastic or monophastic or biphastic waveform. So the monophastic, that's just the one direction. If it's the bi, then it's in two directions. So there's a bit of a chart here. It might be something to know since it's in our PowerPoints. There. So the mono means one, and that's just one direction. It's just going one direction across the chart, across the person's chest. So it's like one direction. If it's two directions, then it's gonna go in a circle. Okay. So I think that's all I'm gonna kind of study. Let's see here. there's this chart that Annie made that might be useful to look at. I just want to look at something in our PN book really quick. Because there is a way that you're supposed to read EKG rhythms. That's this chart here. I'll hold it up and maybe you can see it. There we go. So this first step is to determine the regularity of the rhythm. So like, is it regular? Is it irregular? Is there a pattern to it? You're going to look at the heart rate. What's the heart rate? And then you do that by just measuring the R's, like the very peaks, and then just multiplying them by 10. The P waves. Is there a P wave in front of every QRS complex? There should be, because that's normal. Is the atrial rate the same as the ventricular rate? Are the P waves smooth and rounded and upright? The PR interval, is it normal and consistent? I remember like puberty range. We once said that was 0.12 to 0.20. QRS interval. Is the QRS interval normal and consistent? Do all the QRS complexes look alike? And then the QT interval, is it normal? So this PN book is helpful because I think it just simplifies it a little bit more. Let me just find an example there. Because it'll give you like the different categories of what you're looking for and then like what's normal or what's abnormal. And they also have a lot of these cardiac strips to look at. So if you're needing more study supplies, then I think your PN book is a really great resource for that. And I'm probably going to be studying this a lot more as we go along. And then this is also good because it has on the side like what the wave is characterized by. Gives you an example of it. So with the VFib, that's irregular, no P wave, no QRS. For the VTAC, it's regular, no P wave, wide QRS. Torsade de points, irregular, no P wave, wide QRS. And then it also says like no pulse up there. So supraventricular tachycardia, regular P. Okay, it's regular. The P wave is hidden. You have a normal QRS. STEMI, it's regular or irregular. You have a P wave and the ST is elevated. AFib, irregular, no P wave, normal QRS. A flutter, you have the sawtooth. Regular or irregular, no P wave, normal QRS. And then the premature ventricular contraction, irregular, no P wave, and a wide QRS. And then it'll give you an example here. We have like your normal ones, and then you have all of a sudden like there's one that's not supposed to be there. And then you have the sinus bradycardia. You multiply like 1, 2, 3, 4, 5. Times it by 10, you get 50. That's bradycardia. And then you have sinus tachycardia. You have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. And then you multiply that by 10, you have 110. That's too fast. And then you have the normal sinus rhythm, and this is what it's supposed to look like. And you compare this rhythm with all the other ones up here, and then just kind of like figure out like what's normal, what's abnormal. If you can find a chart like this, like maybe like Google Images or Pinterest or something, then just print it out and like look at it. Look at the rhythm analysis strips here. They have all these really good examples to go through. And then she also like walks through the method about how you're supposed to read the strips to make the most sense. So I think that that's pretty helpful. As I mentioned before, the PN book has a lot of really good pictures in it, so you can see, like, here's a premature ventricular contraction. Like here, it looks good. Then you have this. It's not so good. Ventricular fibrillation. This is when it's just all erratic and not making any sense. There's no normal QRS. Here's when you have asystole, and then here is where you have the ventricular tachycardia. You can see that you still have like a little bit of a normal look to your QRS. This is the ventricular fibrillation, and then the asystole here. So there's a lot of really good pictures in the PN book. And then some of the medications that we probably want to know the most about. Here, so just like the epinephrine, because that's gonna speed it up. The dopamine, and they can also have the atropine. So like if it ends in -ine, just like know that the MIN. So that's bradycardia. You're gonna want a medication like that ends in MIN. Tachycardia, you're gonna use their beta blockers because they're gonna slow the heart rate. You can also use the adenosine too. And that's just gonna help slow it down. And that's also the medication that you're gonna give IV push, and then that's gonna get to have an asystole so that the SA node can reset to a normal pattern. And then for the ventricular tachycardia, there's also two meds here. The Emeraldine and the P1. Probably want to know those. So that's kind of as much as I've studied for. So hopefully this video helps you out a little bit. Just I think looking at the strips as much as you can, just to get used to how to read them. I think that that's going to make the best, like the practice makes perfect thing going there. And then once you look at them enough, then I think that you can start to see a pattern of like what's normal, what's not normal. So, and then also like with some of the cardiac strips, they don't look like other cardiac strips, even though they might both be normal. And then that's where your 12-lead EKG can come in, because depending on which picture you're looking at, the cardiac strip might look different, but it's just taking it from a different plane than what the other one is. So, well, hopefully this helps. And then if you have any study tips that I could use too, you can post them in the comments. I think it's like these study videos, they should be where we can all help each other and not just me telling you like what I think I know, because I don't have all the answers, definitely. And there's like if anyone has like some tips for me, then that can definitely help. One of the things that someone told me once is that if you have like an elevated T wave, that's a bad sign, because the T wave, if it's elevated, it's like a tombstone, and that can indicate an MI. So that's something that someone shared with me. And if you guys have any other tips, and if you just leave them, then we can all learn from each other. Thanks. Bye.